Welcome to the Latin MedTech Leaders Podcast, a conversation with leaders who have succeeded or plan to succeed in Latin America. Please subscribe on your favorite podcasting platform: Apple Podcasts, Spotify, Google Podcasts, Amazon Music, etc. Today, our guest is Antonio Trujillo. Antonio is an PhD, Dr. Trujillo, actually. He's an associate professor at the Johns Hopkins Bloomberg School of Public Health, and he's the director of the school's Master of Health Science, MHS, in Global Health Economics. So, Antonio, it's great to have you here today. Welcome to the show.
Thank you, Julio. Thank you for inviting me today. It's a pleasure to be here.
Awesome, Antonio. So let's get started talking about you. Tell us about you. Who are you? What's your background, and what's your journey to Latin America? How is it you got involved with the region?
Oh, okay. Well, my journey, I think it's going to be from Latin America to the US and then back to the Latin America. I am from Venezuela. I'm an economist by training in undergrad. And then once I finished undergrad, I started working for the government back 20 plus years with what they call the technocrats back then. And I work on privatizations and market oriented issues. I think we partially succeed, but if we see what the situation now, we failed. But I would like to use the partially succeed. You never know. So I have to say that all my the three bosses that I have, the people that I report to, have a PhD, and I dream to have a PhD. So I decided to have my PhD in health economics. So I came here to New York, then Chapel Hill, and I finished my PhD in health economics, which is what was my plan. And then I started working first in University of Central Florida, and then I moved to Hopkins as a health economist. So always, I mean, I do global health economics. I do both domestic and international issues. But certainly, working in Latin America, I always have an edge. I know the markets, know the culture, know the language. So I've been working on health economic issues or economic issues related to the health sector for the past 20 years in Latin America and in domestic issues as well.
Excellent, Antonio. So let's talk about trends happening in Latin America that are relevant to our discussion today. What do you see happening economically, politically, socially, or disease trends in Latin America?
Well, I think Latin American it's always a hard region. It moves ups and down from the left to the right to the middle. So you know, even though I'm an economist, I'm not an expert on macroeconomic issues. I've been living and following Latin America for many years, so I can say that it's a pendulum that moves left right. That's in the political economy arena, and we don't have strong political parties. We have many political parties. Difficult to keep, the center of the ideology. So, you know, government intervention, market, it's always the hot topic, the left versus the right, the equity issues. I think that we will not move there. I think some of the countries are getting, the sense that growing and making the pie bigger, it's better than thinking about distribution. So, there are countries that definitely are growing and facing new problems, but Chile will be one. There are countries who are, back and forth, like Brazil. I think Colombia, it's moving in one direction, hard to stay, but in one direction. So I tend to believe economic wise, it's safe. Um, but you always have to be careful about the movement. But let me tell you about the health and what I do and what I think it's going to be the big issues in the country, or at least what I think. I think the issue of managing multiple chronic condition, people with multiple chronic condition, and aging society will be very, very crucial. So we're talking about long-term issues, longevity, and people getting sick. We used to believe that we have the informal care sector and this is human capital taking care of the people, but the more I see the data, the less I believe that we have, that these people getting older will have the younger people taking care of them. In part because the younger people, in part because of good news, the women at home, the younger people are getting education, they're getting jobs. It's harder for them. So I think a very issue that I care a lot about it is how can we get these people healthier, having each year of life better? How can we make the social security and the social structure better for the elderly? And this is I'm saying long term, but this is medium or the problem that a lot of people have right now. So you look at COVID, the group who was more affected by, and we didn't have all the infrastructure. We just went and say lockdown was the senior. So I pay a lot of attention to that. I pay attention to chronic conditions. How can we control costs, provide good care, identify people with chronic conditions sooner? So health is very important. We used to think a lot about health and education in early stage. I think we need to invest in education, human capital, of course, but we need to pay attention to the health of the elderly. So that's what I'm doing a lot of work.
Okay, okay. So let's talk specifically about countries where you've worked in Latin America. I understand you work directly with the governments of different countries in the region. Let's go one by one. If you could give us a quick summary of what's going on in the countries you're very much involved in right now, like Colombia, for example. Let's talk about it.
Yeah. Colombia, it's a very interesting healthcare system. It have a very important healthcare reform 20 years ago. So you have a system where, even though you have the public using taxes, you channel the money through sickness funds or decentralized. So for your audience, imagine that you have a Medicare or Medicaid, but you have many Medicares. So people can enroll in different sickness funds. And EAPB and that competition, and that introduction of the market, increase investment, increase supply, increase efficiency, not without problems of equity and issues like that. And there is no perfect solution. So Colombia is an interesting place. I've been working a lot in Colombia, open the market for private sector for investment, improve curative care. So how do I get into Colombia? Last 2 years, I've been working a lot, advising the government in policies related to COVID-19. So, since the beginning, since the beginning, the issue was the lack of supply because many people were having that. But when you saw the numbers, Colombia 2 years ago have 6,000 intensive care unit. Today have 12,000. So, and 6,000 was 10 times more than Peru or more than that. So you can see the effect of having this private sector government, um, you know, uh, role in the health sector. You have better surveillance system, and despite that, Colombia have 4 million cases, a lot of death. So it's a very, very complex problem. So in Colombia right now, I'm working mostly on COVID-19.
But
But
before that, you work also with the Colombian government. Before the pandemic started, you were doing some
a
work.
lot of work
Okay.
in evaluating the health insurance packages, what benefits should be provided at what price, what are the health outcome effect of providing these packages in a decentralized way. How can we control the cost of provision? Yeah, a lot of issues related to economics and health. So in Peru, I have done working on diabetes. So basically, how can you improve self-management of diabetes? So we know that if you take care of yourself, a patient with diabetes can be longer, but we know the technology, we know the information, we know the standard of care. And if we provide the standard of care, we have better outcome. The question is, how can we improve outcome also in a system where you have big differences in quality between private and public sector? So that's very interesting work. I'm also doing some work on mental health issues, and how can we identify costly mental health issues earlier. So
In Peru,
given
right?
in Peru, given
Yeah.
the market that we have. So
Okay.
um, that's two cases. I have done a little bit of work in Mexico, Brazil, and Costa Rica. There is a data set called SABE data set. And basically, for your audience, that's a household data set. You go People go and collect data for the about the elderly in all of these countries. 10,000 households, and that data is available. So I have seen how cognition decline, how people with more than one chronic condition impact the labor supply of people in their households. So I have used these surveys, and I provide advice to different governments related to issues associated
Interesting,
with
Antonio.
longevity and labor force participation.
Okay, now you're bringing up the issue of data sets. What's the state of finding good data sets in Latin America? I usually hear that it's very difficult, that there are no centralized locations to capture the encounters of a healthcare system. I understand that Colombia, the Ministry of Health, has something called CISPRO, which is believed to be the best in Latin America. And please correct me. I mean, what's the state of data sets in Latin America? How difficult it is to do epidemiological research in the region?
Well, Julio, epidemiology is not my area, even though I use data or participate in the design of survey. I usually end up using survey. But so let me tackle your question in different ways. So one traditional way that we social scientists trying to learn about the health of the population is to do household surveys. So we get a representative sample of the population and we ask several questions. Those are long surveys, cost millions of dollars. People go to each house and they respond. So that's what is called household surveys. So there are very good household surveys in several countries in Latin America. Actually, the survey follow the structure of what is called the health retirement survey. That's for the elderly. And for the non-working, for the working population, there is a similar survey that follow the structure of a U.S. instrument. So similar question, very long. So that's one source of data. So the let's call the retirement survey or the elderly survey. Mexico have that data. Costa Rica, Brazil, Panama, Colombia, Chile, Argentina. So a lot of we can have a very good sense of the health of the population of the elderly by looking at that data set. The other issue that I have to say with this data set is that data set is measured in different point in time. So for instance, in Costa Rica, in Mexico, I have used the data set in 2000, 2009, and 2018. So you have three waves of data. So some of the people in that data set is what is called a panel. So we follow Julio who get older. So you can control for things that happen while you are getting old. So that's issue number one. So there is a lot of household data, panel or cross-sectional. Cross-sectional means that I measure different people in different point in time, or panel data. And there is data about labor market issues and issues like that. Now, people who will say, well, that data have problems like everything in life. Yes, they have problems. People tend not to participate in the surveys. We have control of quality, but this data is available and usually free. So social scientists in university use those data to publish and to get to know more about country health. Second issue, claim data set. So Colombia have a wonderful claim data set. Claim data set mean the payment that insurance companies do to provider. Colombia have a wonderful claim data set because what I told you, they have the EAPB, and the EAPB has to report all the payment that they have. I don't want to get into the detail how they funding the system, but the point that I'm trying to make is that the claim data set mean the insurance provide all that information, so I know how much the insurance pay for which treatment and how much the consumer pay. So that's claim data set. So Chile will have a good claim data set. Colombia will have a good claim data set. When I go to countries, I have to be creative if I go to other countries. So creative means which one is the strongest insurance company in this country? Can we get that data? Or do I work with them? That's second source of data. And then I think we need to be creative in collecting data. I mean, large data set sometimes have weaknesses, and we need to be creative in collecting other type of data rapidly that complement or give us the information that we need to make decisions. So for instance, in the United States, we use the Amazon Turk a lot. So we used A/B type of testing to see how people preference change when I present this information about this medicine. I use A/B trust testing or Amazon Turk when I wanted to have a sense of an issue rapidly. So I don't know to what extent can we use telephone interview, quick telephone interview, or online settings. Now the downside would be that not a lot of people will participate in this Amazon Turk. So to be quite frank, I don't know if Amazon Turk, that's a platform where people get paid if I answer the surveys. And you can do qualitative research or you can do rapid assessment of research. So to conclude, there is good data set, better than in low income settings. Some of the data set are available in universities. It's a matter of looking. Some of the data set depend on your client. Pharmaceutical company could have very good internal private data set that will help you to make decision. And then government may have records and now depend on the type of job that you're doing, but it's part of the game. Getting the best data to make a decision, and you will be making decisions not with full information, and you're going to
Yeah.
make the best out of the information that you have.
Yeah, sure. All right, so let's talk about the healthcare system of the quality of the healthcare system of the different countries in Latin America. I usually hear or read online that the healthcare system in Colombia is one of the top performing healthcare systems in the region, according to the WHO. Is that right? Is that still the case? How would you rank the healthcare systems in the region?
Well, let me tell you that I'm it's very difficult to rank healthcare systems. So, because how do we measure? If I wanted to rank something, I tend to rank based on outcomes or effort, and both are very difficult to observe in the healthcare sector. I mean, I could have the best doctor, but the outcome is that I die in a almost
Yeah,
perfect surgery because there is a lot of external factor. And then the
I
effort
see.
and the quality, it's very hard. I need a year of education of the surgeon. I need a lot of input to really compare apples and apples.
Okay.
I like to say that those people who compare mortality or life expectancy is like comparing a drive from point A to point B, and I take a Porsche and you take a Corolla, and my Porsche is $1 million and your Corolla is $20,000. We go to A and B in the same time. So if the outcome is time, you did even like the same. So if I divide outcome minutes per million, I'm much more expensive than you, but it is not reasonable, in my opinion, to compare the ride of the 1 million car. Now, depend again on outcome and the input that you wanted to put. So uh, now, if we compare with life expectancy and issues like that, you're going to have access to care. You're going to have a mix. But again, Colombia have a pretty good healthcare system. You need to improve access in certain places. Good training force. A lot of doctors coming to the market, well trained nurses. So when I look at this, I'm not only looking at the macro data, healthcare as a percentage of GDP, but also human resources, heterogeneity in the region, and what kind of policies are in place to grow the system and to control costs and issues like that. So now I wanted to take your question in one direction, which is important. Most of the reforms in this country and even in the US for the last 30 years, the healthcare reform has been referred to access. Let me give insurance to people. Let me give. If we learn something about COVID-19 is that in pretty much all around the world, the supply of healthcare sector was very uneven and not as we needed. We need to invest more in supply. We paid too much attention to the demand side and we forgot a lot about supply. Even in United States, we have an uneven balance of beds, hospitals, doctors, and that's why a lot of people die in places where you didn't have a lot of. So if we need to learn something about the healthcare system, is that we need to invest. So now investment. Healthcare, it's not a typical private good. So you need both government and private sector. not the stream, not just government, not the private sector. So I wanted to take this moment and this opportunity that I think the government who start thinking more carefully about how to bring private and public partnership to expand supply will win in the long run. We need to increase again supply of machines. We need to increase supply of inputs that we need in difficult times. So all of these discussions we need will take place again, and the ones who decide to open the private market, open the stock market, the private investment through different channels will gain. The health sector, it's the most important sector in the economy because we need it sooner or later, or at least if we don't need it, we need to know that it's there. uh, when I need it. So we need to invest, and we need to be not afraid of having overcapacity.
Interesting. Okay. So let's talk about the quality of the healthcare system. Let's use that measurement. Where in Latin America would you say you find the best quality of healthcare?
And you're giving me a hard question, but let me say it, go back because I know that your audience a lot are related to investment. One area where I think a lot of opportunity is investment in nursing homes, investment in elderly care. So I didn't complete my previous part with that because I really wanted to bring the attention of your audience and maybe an entrepreneur to think about, okay, where can we invest in these countries, where can we there is room for interesting partnership between the government. So if the government is paying a lot of attention to infant mortality, every dollar that you invest in the elderly care and improve will be saving for them. So that's the kind of thing that we need, numbers that we need to show the government to create incentive for the private sector to invest. So now going back to your question, you're asking me questions that are difficult, the quality, right? How will you measure the quality? So if I have I don't know, a high brand good quality, may be the price, the signal, uh, but quality may be how much they last, the inputs that were used to produce the output. We can discuss, and I don't think that we have an agreement in the health economics, what really is quality. So quality could mean intensive of care for episode, and what do you do, what equipment, what medicine do you use to save these people, even though that the
I
outcome
guess I'm
was not
using
there.
the wrong word. Probably the question is
No, no,
how
no.
can we
I
measure
mean,
the satisfaction, the patient
we
satisfaction?
no, I was going to go to there.
Yeah.
Okay, the
Okay.
other thing. Okay, so I was going to go to there. So I'm just trying to say that it's we tried. I'm just trying to say that it's difficult. So you can say the input that are put into to produce the output. So quality of care. Now, in quality of care, we need to be careful in Latin America. Are we going to compare the stream of the private provider or the average? Are we going to include in the mix the best public sector hospital with the not so good public health hospital? How are we going to really measure quality and put it together? So economists try to do this in aggregate or try to look into one specific service, catheterization or any type of treatment, and then we see the input, what on average a consumer will be used, and we measure that. If we're going to get into more, what is the quality of the doctors, the nurses, all of that. But in aggregate, we say number of hospital, number of beds, these things like that are aggregating quality. So there is a long run to go to improve quality in the healthcare sector in Latin America. I think it's always a trade-off between access, quality, and prices. You increase quality, you increase prices. How much out of the GDP people wanted to compromise in healthcare sector? And then, once you start investing in the health sector, incentive matters. If you have an open system where you pay the doctor fee for services, sooner or later you're going to have what happened in the US, difficult to control quality and cost. And always this is the trade-off that we hear in the economy, in the US. You put the incentive to improve quality, then you pay for high cost. You feel like you're wasting money, and you can do better with less. So quality matter, incentive matter. If you want me to look in Latin America, I will think about access and quality. I will look into how the system is funded. Not only what taxes are used, but what method of payments are used. Usually in Latin America, the method of payment used are salary. So if I pay someone based on salary, you may imagine, and if I paid a hospital based on global budget, you may imagine that you will control costs because I will know how much you will be your salary and your budget next year, but quality will not go up. So to answer your question, when I have that and I travel and I see places in Africa or US, or I tend to look at incentive, method of payments, how do you pay your doctor, your hospital, how an hospital could be better over time. What are the competition? If it doesn't have competition, what are then the incentives to be better and to improve in a dynamic way over time? So that's to me how I look into quality. So most of the Latin America hospitals are not paid based on incentives that induce quality. You can say that is intrinsic motivation, maybe, but I, as an economist, I tend to believe that the intrinsic motivator matters. So if I don't know the names and I look at the GDP, look at how much percentage, I see how much more money you put, you can expect that the life expectancy will be higher in the richest places, but quality you need to dig more into the kind of things that I'm telling you. Now you say something interesting, which is consumer. How do we measure consumer satisfaction, Julio? We have what is called exit interviews. We have interviews. So we ask the consumer, because you're right, if the consumer come back to buy the car, that's a good car. If the consumer didn't complain about the car, that's an excellent car. If the consumer complained about health, that doesn't mean that I was a bad doctor. But it's always the balance for the health economists and the discussion that we have with other professionals. How can we include the voice of the consumer? If the consumer have full information, the problem here is that the consumer does not have full information, and the physician or is the agent. He's making decisions for me, and we need to trust. So, and trust and these issues become really important in this relationship. So, my answer to your question, if I need to say something about Latin America, is we need to look for ways to incorporate the consumer voice more into our assessment of quality. We are not quite there, but as you move there, you're going to see that there are limitations. But we really need to hear more. We need to trust more, and that the consumer could make certain decisions. Surgeries that take time, the consumer can shop around. A lot of care with full information. The consumer could balance the out of pocket, the cost, the healthcare cost, the health consequences, and make informed decisions. So I believe that the consumer voice matters, not as much as in other sectors, but we need. I always tend to bring that into the table. Last issue, consumer matters. I mean, I'm seeing a lot. I'm talking a lot about the size of care. I'm not talking about the finance part, which is the consumer may matter a lot choosing insurance. Consumer may matter a lot into consumer information may matter a lot into uh, picking up care that it's fully or half out of pocket. The eye care doctor, the therapies, the dental care, all of these things are really important in your health. So consumers, it's an important driver in the competition and therefore quality of care.
Antonio, we're close to the end of the show, but I have a couple questions here.
Sure.
One is reimbursement and market access for a foreign company that wants to sell devices or drugs. It's really, really important to understand the reimbursement landscape, how easy it is to get paid, right? Because if you want to sell in the market, you want to capture the largest population, which is the public healthcare system, right? Where has a code, right? Like in the Medicare system in the United States. So, in terms of reimbursement and market access, what would you say about Latin America? What's the state of that? What countries are easier to enter as a foreign company to sell something knowing that I'm going to get reimbursement really quickly?
Well, I think one issue that I observe is institutions. So if the institutional culture and the institution who value therapies or equipment are there, you made trade-off, high return, very rapid, based on context and this type of investment versus having something more settled, evaluated, and uh, uh, lower pace return, but more secure. So, to answer your question, I would say that I will pay attention to how the government get reimbursed, but I will pay attention to the type of institutional setting. So, if I look at a country where a device is evaluated, the institution gives the green card, it will take time. But once you pass that door, that flag, then you are in the health plans that are covered. You are more secure. That's issue number one. The second issue, I will know my numbers, and I will know my big numbers. The first thing that a company, and I help companies in that direction, it's how much cost what it's right now, how much cost the government, not only monetary but also in terms of working days, in terms of health, the technology that you have, the medicine or the equipment, and then if you use this one, how much you save. Again, in the gains. You really need to convey it rapidly to the government. If I give you this, you have saving. Put that money in the street on, making your street safer. Put that money in public school. Put that money. So, uh, you really need to have your elevator pitch very quickly in terms of savings. So I will say that if you're getting into the issue with the social security big institution, it's going to be slower, but if you make it, then it's going to be more secure. um eh, yeah, I think most of the investment in Latin America, if you wanted to reach for the larger market, you need to go with the public institutions. So I will pay attention to the how stable are these institutions, how long
Okay.
have they been in place.
Okay. All right. So another question before I jump to the last question.
Sure,
It's a
sure,
follow
sure.
up
No, I'm
question to
having
this
I,
one.
I'm having fun. I hope that your audience are having
Very
fun
good.
as well.
um, I understand, or is there a relationship between reimbursement or ease of entering the market and healthcare being a constitutional right in Latin America? Because in many countries like Colombia, for example, like Uruguay, etc., healthcare is a constitutional right. You have the right to receive healthcare regardless of the price. So in Colombia, for example, if something doesn't have a code, a treatment, a procedure doesn't have a code, it's called the CUPS code. Uh, if the doctor can justify to the system that I need that medical device or that drug that is available overseas at whatever price it is, the doctor can submit that application and the system has to pay, even if I have to go through the Supreme Court to get my right respected. But I can get paid as an insurance company or as a hospital, and as a patient, I can receive the treatment that I need. Is there a relationship there?
Yeah, no, I think you raise yeah, again, a very interesting and complex issue. And I was trying to get at that with understanding the landscape of your institutional settings. So you're right. In a lot of these countries, believe it or not, something is a constitutional right, and the starting point is that a lot of my constitutional rights are not in there because if I live in a rural area in certain place, I don't have the right to much anything. So
That's true.
um,
Yeah.
so I'm not so sure when I got into the discussion with legal scholars and experts what really means, but what it means is means complication through the court system. So you really need to understand your system. Now, what you suggest, so let's have agreement in certain areas. We need to have a safety issue. We need an agency. FDA is here. In other places are called in different ways, but we need someone who say this is safe to be used. I agree with that. Now, these agencies have to be more efficient, understand how to improve, but we need the government for that. We cannot, when I say the government can contracting out the studies, the government can do, but we need someone to say that. So we agree on that. If it's safe, so we need to go through that. In healthcare sector, it's not an iPhone. We need to make sure that the things that the public will use are safe. We all agree with that. Then we need to think about, if it's the public sector, the finance, do we have money to reimburse to cover this? So if we need to think about that because we have fiscal constraint, then we need someone to say it's better to use this than this. It's better because it's cheaper and better in quality, or it's better because it's more costly but it gives me more quality. So that's, I mean, if someone gives you lower price and better quality, there is not a question here. So, but if someone gives you more cost but better quality, so, and then we need the agent that you say, the doctor. So yes, if we have this institutional settings, we have less complication. If we get around those uh, settings, or invest directly, and you know, then you start having problems. And now this type of issue where the things can end up in Supreme Court, it reflects that you have more different parts of the system, the institutional setting, to sort out this. Now that reduces the speed of investment, capturing new market. I if I need to advise the government, I will say you need to make this process to go faster. We need to open the opportunity for the private investment in health to happen. So all of that need to happen faster, but we need to agree that we need government. We need strong government to safety. We need a strong government to look at the finance implication of the reimbursement. How can we, again, open market and all of that? I don't think they're going bypassing that. Think about the Uber model.
Hmm.
Uber went to all the places, provide the services, consumer fall in love, and then the legal start happening. So we cannot afford that in health, because if you use a device that it's not safe, then people die. And no matter how much you're gonna price life, it's gonna be a really, really big important issue. So it's a different strategy, different way to move. And again, the public sector should be strong, but should create all the incentive, the correct incentive to maximize private investment, both domestic and international.
Agree, agree. Yeah, because one of the big issues in Latin America, and correct me if I'm wrong, is the delayed access to medical innovation. It will probably be about 10, 15 years before a product is available in the United States or Western Europe, until that product is available in a small clinic in Venezuela, Peru, Colombia, Chile. So
Julio,
there's a
we
big gap.
I totally agree. Let me give you one example related to COVID, and then listen. We took advantage of the rapid innovation that happened in the U.S. with the World uh, program, right? The machine came into the market in record time. I mean, let's not go over whether or not it's completely safe, no, but it
Yeah,
really,
that's another
it's
story.
it's it's a first step of a game changer, right? Now we have three main machines, and we say 12 days, this dosage. A very simple way to expand supply would have been to say, I will give you Moderna, but half and half. With half, I could double the supply that I have.
Yeah. Hmm.
The testing of that should have been done very quickly in domestic economy, not in the US, and then sign contract and say, so I'm giving you an idea of how these institutional settings who provide care, who provide the assistance to the society to make sure that something that getting to the market is safe, should work faster. One
Yeah.
example is, if we would have been much faster testing devices, testing uh, combination of machines and issues like that, we could have solved problems much quicker. Colombia did some of that, but not up to the extent that I would have liked. And other countries are way behind that. So issue number one. So issue number two, if you already know that this device is effective in different countries, why you will not have a rapid
Yeah.
approval?
Exactly.
So now,
Yeah.
I don't want your audience to get confused, because the same thing happened in the US. Amazing could be approved in Europe, and we don't use the FDA in Europe, which is the Federal Drug
IMA.
Administration in Europe.
Yeah.
It's have a different name. I don't know. We don't want to
IMA.
get too technical to your
Yeah.
audience.
Yeah. Yeah.
We don't have this rapid approval saying, well, if the trials were done, were approved, what will make a population in the US so different, and why
Yes.
will it
Exactly.
stop
Yeah.
such an important medicine for so long. So it's
Uh-huh.
always balancing a very important trade-off: safety versus rapid access. So we have different mechanisms, institutional mechanisms, accelerated approval, you know, different ways to reimburse devices or medicine to expedite uh, access into our market. Your point is correct. We need to expedite investment, access to good technologies that are out there, that if
Exactly.
we provide to the market, we can save years of life, we can improve quality of each life of each year,
Yes. And
we
we can
can
save
improve
money too.
medical care.
Hmm.
And making money providing something of value, it's good. So I hope that, I'm in a health sector. A lot of people are more pro public sector. I'm pro strong public and private partnership. So I think that the government is a key player here. I already told you in many dimension, regulation,
Yeah.
all of that. But I think that a government that is looking for private investment, maximize private investment, provide opportunities, well regulated, will win the game in the long term to provide better health to their citizens. So
Agree. Yeah.
it's maybe not a message that win election, but it's a message that improve quality of government.
I like that. All right, Antonio. So, what's the profile of your typical client? I mean, you do consulting work through the university, right? And who seeks your help?
Yeah, well, Well, let's say I work in a university that it's called soft money environment. So soft money means that you need to look for your project to pay your salary. So I'm an entrepreneur in academia. So if I don't have the project, I don't basically pay my bills. Part of my salary, it's hard money, meaning because I teach. So I teach and then I have clients. So I could also do private consultants. So who are my clients? So my clients could be the government, the federal, the MOH, the government in certain state. They wanted to improve quality of care. They wanted to control costs. They wanted to know reduce mortality. They wanted to improve right now productivity of labs. The labs, it's an economic issue. They are producing tests. How can we produce tests more rapidly at a lower cost? How can we integrate this technology? So this could be my big project. So for instance, I do a lot of work on biosimilars, genetics. How can we make sure that the market for genetics are competitive, that there are not any type of anti-competitive behavior, barriers to entry. I do work for branded companies, government. I mean, how can we, deal with high cost medicine? A medicine that costs a lot of money. So usually those are the government type of project that I have. Now, I could also have um, clients that are private. I do large research, so most of my work is research with private company. How can we define a program that help to reduce the cost of treating our patient with diabetes? How I can get a patient who I identify early not to become very costly in the future. So with a lot of private company will ask me about that. How I can predict that this person will be very expensive. How I can change the trajectory, basically improve my bottom line. So I do research on that. Private companies are also very open to do experimental intervention. If we provide these type of scenes, so I love these kind of scenes. And then, I do also policy, not research, but policy. So in this case, it's more, we have this problem, five experts have heard this problem in other settings. Let me talk 2 hours with you, how to see how you see these issues. So
Best practices. Yeah.
best practices, I have this problem, what would be the best way to solve it? So in conclusion, I have research at some time. You know my research is funded by federal agency like NIH, and then we do research in with that money in Mexico or Peru. And these are research that, like I said, how can we improve the self-management of people with diabetes? Is federal money. So that could be also my or USID. USID may give money to different countries to improve the healthcare system. So I help USID with local partner. So I have a mix. The good things about economics is that we have range. We use our tools, understanding incentive, how incentive change behavior of organization, people, consumer, patients. So we use our tool in different
So
settings.
all the stakeholders can use your services, right? Your
Yeah, yeah.
consulting
So
research services. Yeah,
exactly. I tend to be mindful of conflict of interest.
sure.
I have done work for pharmaceutical companies. Usually, pharmaceutical companies may be interested to explore, you know, certain services. What are the if we try to get into this market? Are there some barrier in importation, distribution, supply chain? So this is strategic analysis. We also tend to do it,
Great.
and then individual consultancy at side hubs. Correct.
Excellent. Excellent. Well, Antonio, we're close to the end of the show. It's been a delightful conversation. And how can people get in contact with you?
You look at Tony Trujillo online, and it's gonna be my picture of Hopkins, and you're gonna have my email. But you can give to your audience my email. But in nowadays world, everyone can search. I don't have any social media, anything like that. I'm not good at that. But if you go to Google and you say Trujillo Hopkins, you go see my profile. And then I
All
will be
right.
happy to answer an email, or if you need any more information about a specific issue. It has been very fun and delightful, as you said, to talk to you. Maybe in another day we can talk more about the market for medicine, which is something that
Yeah.
I'm been working
Okay.
in the last 5 years very intensively, and it's a lot of interesting issues out there
Yeah,
on
I'm sure
access
we
to
can talk
medicine.
for hours. Yeah.
Yeah,
All right, Antonio. Thank you so much for being the show. It's been a
Julio,
great
always a pleasure.
conversation. Bye bye.
A
Take
pleasure to
care.
talk to you. Take care.
Thank
Bye.
you. Bye.